All right, good afternoon, everyone. Thank you so much for joining us today. My name is Haley Aka. I'm a senior policy analyst at the Health Policy Institute of Ohio. And thank you again so much for joining us for our webinar, Taking Action to Strengthen Ohio's Addiction Response. HPIO is an independent and nonpartisan organization. Our mission is to advance evidence-informed policies that improve health, achieve equity, and lead to sustainable healthcare spending in Ohio. I want to thank our core funders who advance our mission with their steadfast investments in our work. I'd also like to specifically thank Interact for Health for their support of these final briefs from the Addiction Evidence Project. We encourage you to tweet throughout today's webinar using the hashtag HPIO Forum. You can also keep up to date with our latest publication releases, our events, and other current events in the policy environment by joining our mailing list. Here are also our handles where you can join us on Twitter and LinkedIn as well. If you have questions for our presenters today, please feel free to type in the question box. We'll get to as many as we can during our short half hour together. We can also discuss some things in chat if that's a better venue for that. So please feel free throughout today's presentation to be typing in there. And remember, during our time together to stretch, to move as you're able. Let's keep our minds and bodies engaged during our time together. All of the resources that we're presenting on today, as well as the slides and recording of today's webinar, will be available shortly after our session today on the HPIO website. You can find those after today's event by going to hpio.net and clicking on events. And with that, I'm going to pass it over to my colleague, Amy Bush-Stevens, who's going to get us started this afternoon.
Good afternoon, everyone. We are so glad to have so many of you on the webinar today and to share with you a policy brief and fact sheets that we released this fall. Move this along here. Okay, this is the culmination of our Addiction Evidence Project, which we launched in 2017. And this work has been comprehensive. We've addressed all of the topics and sectors that are shown here. Throughout the Addiction Evidence Project, we have identified opportunities for improvement based on an inventory of policy changes in Ohio and information from the most credible sources on what works to address addiction. We have produced 9 publications as part of this work, and I want to take a minute here to thank our advisory groups. We have had, throughout this project in every phase, we have had advisory groups made up of representatives from many different sectors, and they have provided us with really, really helpful guidance and an ear to the ground. And I know some of them are on the call today, and we thank them for their input. Today, we're going to be focused on the publications that we released this fall. And in this wrap-up policy brief for the project, we do 3 things. We provide an update on trends, we have a summary of strengths and gaps, and put forth a prioritized set of recommendations. Here are the big picture key findings from this policy brief. Ohio has a strong foundation for future action. More can be done to prevent overdoses, and criminal justice reform is critical to progress. We are going to start with a look at some key trends. The percent of Ohioans with substance use disorder has remained fairly steady in recent years and is similar to the US overall. However, our overdose death rate is much higher than the US and has sharply increased over the past decade, largely driven by changes in the drug supply. And you can see those 3 waves of the overdose epidemic listed across the bottom. Since 2016, fentanyl and related drugs have been the most common drugs present in overdose deaths. One study estimated that 93% of the change in overdose deaths from 2009 to 2018 was explained by changes in the lethality of the drug supply, including the spike in carfentanil that we saw in 2017. And fentanyl is increasingly being mixed with other drugs like meth and cocaine. It has been frustrating and devastating that the number of deaths having continued to increase despite all of the great efforts around the state at increasing access to treatment and expanding access to naloxone that I know many of you on this webinar today have been directly involved in. So we put together this framework to talk about all the different factors that drive overdose death so that we can really be thinking about this in a comprehensive way that also takes into consideration risky drug use conditions and the lethality of the drug supply. So making sure that we're looking at all of these factors. And we get into more detail on this in the overdose death fact sheet. Here's some other trends in downstream harms that we look at in the brief. Here, the trend has been more mixed. So for the drug crime arrest rate and the number of children removed from the home, we saw that steadily increasing until about 2018, and then they started going down. Of course, the numbers in 2020 were likely affected by COVID, so it's going to be important to look at these trends through 2021. Now we'll look at the strengths and gaps of Ohio's policy response. Here are the strengths that we highlight in the policy brief. And I'll provide a few examples of these. Expanded access to addiction treatment has been a major focus for the Ohio Department of Medicaid and the Ohio Department of Mental Health and Addiction Services. And these quotes illustrate the perception that it's now easier to get into treatment and that more people are getting treatment instead of jail. And here's some data to look at this trend. Here, the increase in medication-assisted treatment, specifically buprenorphine and methadone, which are both highly cost-effective forms of MAT for opioid use disorder, but of course they don't work for meth or cocaine. Policymakers have also focused quite a bit on naloxone distribution. So here is a quote talking about what that increased access means to people in the community. And this is data from Project Dawn showing the increase in naloxone distribution, and that red line there is the number of known reversals. So those are documented overdose reversals. Obviously, there are many, many more, but you can see that many lives have been saved and surely many more than that. So even though the situation is bad, it would have been worse without these efforts. And here are the biggest gaps and challenges that we highlight in the brief. As I mentioned earlier, the increasingly deadly drug supply is a major challenge. Despite many well-intentioned efforts to decrease the drug supply, drugs in the illicit market have become more and more lethal. Another challenge that stakeholders report is the need for additional recovery supports, particularly recovery housing. There are 42 counties with no certified recovery housing, and most recovery housing does not accommodate families with children. These challenges can feel overwhelming, but there are definitely things that we can do. And so it was important to us in this final policy brief to present a set of recommendations. We narrowed down to a list of 9 recommendations based on feedback that we got from the advisory group. And then we further narrowed the list based on potential impact on equity and the other factors that are listed here. We identified recommendations that need to happen immediately in order to reverse the overdose death trends that we're seeing, as well as other recommendations that will take more time to implement. To save lives by ending fentanyl overdose, we recommend removing all barriers to overdose reversal, increasing drug checking, such as rapid fentanyl testing, decreasing the lethality of the drug supply. Those are the 3 areas that we focus on there. Now we'll look at some examples. We can remove barriers to overdose reversal by increasing outreach to grassroots organizations. So in particular in low-income communities, Appalachian counties, and Black communities. This could be done by extending the Recovery Ohio Overdose Awareness Naloxone Access Program. Extending that through 2022 would be helpful. We can also improve our Good Samaritan law by removing the restrictions that we have. For example, there are restrictions for people on parole or probation, or the number of times that a bystander can reach out for help. We need to get rid of those restrictions so that this is stronger and more people can get help. Fentanyl test strips allow people who use drugs to test for the presence of fentanyl. And we can increase access to this life-saving technology by explicitly making these test strips legal. And there's actually legislation that was recently introduced that would do this. And we can also do more to support community-based syringe services programs that really serve as the hubs for harm reduction services in our communities, including drug checking. Over the next 2 years, we also think it's critically important to focus on criminal justice reform in ways that will support recovery and housing. We highlight these areas here. Look at some examples. Momentum is building in Ohio and across the country to replace money bail with comprehensive pretrial services. So this would decrease the number of people with substance use disorder in jail. There's also interest in eliminating excessive collateral sanctions that keep people with criminal records from being able to get housing and employment. And then finally, this third area here is to strengthen Ohio's prevention, treatment, and recovery continuum by investing the opiate settlement dollars to maximize long-term effectiveness, to increase treatment capacity, particularly through telehealth and workforce development, and to guarantee access to medication-assisted treatment and recovery housing for everyone who needs it. So looking more specifically at the opioid settlement, we need to ensure that the statewide foundation established by the One Ohio plan sustains long-term investments in what works, including efforts to prevent and mitigate childhood trauma that we know is such a problem. We can continue the gains made during the pandemic to increase access to telehealth by updating professional licensure standards to support more open access to all forms of telehealth, And the Ohio Department of Mental Health and Addiction Services and the Department of Medicaid have removed many barriers to telehealth, such as restrictions on audio-only appointments and requirements for in-person visits before a virtual visit. These things have all greatly increased access to behavioral health treatment and should be continued. And there is hopeful progress happening right now. The medical board recently extended some of these provisions, and Haley's going to say a bit more at the end. So hopeful progress here. Now, Jacob Santiago and Lexi Chirakos on our staff are going to share findings from 2 fact sheets on equity. And before we jump into that transition, I'll just check in with Haley and see if we have any questions that we need to address.
I think we can keep moving for now, Amy.
Okay.
And we'll look at the questions in the chat and we'll address them at the end.
Sounds good. All right. So Jacob and Lexi are going to focus on 2 fact sheets focused on equity. Lost my power here. If you could take me to the next slide. Great. So they're going to look at disparities by race and geography. And first, I just want to say that we know that substance use disorder is a concern across the state, and people in any community can be affected by addiction. However, when we look at the downstream harms of addiction, so things like incarceration, hepatitis C, and overdose deaths, we know that Ohioans of color and people living in Appalachian and urban counties are more likely to experience these downstream harms. So these are some of the common themes and drivers of these disparities. And now I'm going to turn it over to Jacob to talk more about that.
Thank you, Amy. Good afternoon, everyone. I will be walking us all through some of the key factors driving downstream addiction-related harms for Black Ohioans. Unfortunately, a lack of data prevents the downstream harms of addiction for other Ohioans of color from being fully explored. I will also spend some of our time together highlighting some opportunities for improvement Ohio policymakers can take to ensure that Black Ohioans and other Ohioans of color have the supports they need to access and sustain treatment and recovery, prevent adverse childhood experiences or ACEs, and achieve optimal health. At a high level, these are the key factors and drivers that we explore in the Insights on Race and Addiction fact sheet. Racism in the criminal justice system, childhood adversity and trauma, and a lack of access to harm reduction, treatment, and recovery services. Historical and modern day criminal justice policies and practices, such as tough on crime laws and the enforcement of such laws being centered on urban areas, low-income communities, and communities of color, continue to negatively and disproportionately impact Black Ohioans. These biases have led to the disproportionate incarceration of Black Ohioans. In 2020, Black Ohioans were 5.4 times more likely to be incarcerated than white Ohioans. And we know that incarceration follows people into the community, as formerly incarcerated people experience greater barriers to accessing treatment and recovery services once they return to their communities. Adverse childhood experiences, such as the incarceration of a family member or substance use in the household, increase a child's risk of experiencing negative health outcomes later in life. These can include substance use and addiction. And while every child can experience adversity, Black children were 1.8 times more likely to experience an ACE than white children in 2019. And while evidence-based alternatives to incarceration, such as drug court programs, have been expanded across the state, not all Ohioans have access to these services. For example, this slide displays the percent of Black and white Ohioans who have been enrolled in drug court programs compared to their percent of drug arrest in their percent of Ohio's overall population. The red lines, which cut across the two bar graphs, display the percent of Ohio's population that is Black and that is white. The bars on the left display the percent of Black Ohioans and white Ohioans making up drug arrests in the state, and the bars on the right display the percent of white and Black Ohioans who have been enrolled in a drug court program. This analysis shows that Black Ohioans make up more of drug arrest than their share of the state's population, contributing to the large incarceration disparity I noted earlier. But they are not enrolled in treatment courts at the same pace as white Ohioans in the same position. All of these factors drive the worst outcome, overdose deaths, among Black Ohioans. In 2019, the overdose death rate for Black Ohioans surpassed that of white Ohioans for the first time since 2006, as combinations of cocaine and fentanyl became a more common driver of overdose deaths among Black Ohioans. However, these drivers and outcomes are not inevitable. We know what works to improve addiction-related outcomes. To support the health and well-being of Ohioans of color, Ohio policymakers can do a couple of things. They can reform and revise criminal justice policies to support addiction recovery. This can include increasing the number of Black Ohioans enrolled in treatment courts and pretrial diversion programs. Policymakers can also reduce childhood adversity and trauma by implementing evidence-based strategies, such as those identified in HPIO's third ACEs brief. Ohio policymakers can also increase access to treatment and harm reduction services, such as maintaining the telehealth policies developed during the pandemic that Amy noted earlier. We know that these factors are certainly not the only ones driving disparities and addiction outcomes in our state. Lexi will now take you through some of those other factors and what Ohio can do to improve them.
Thanks, Jacob. And thank you everyone so much for being here today. So Jacob just took us through some racial disparities in addiction-related outcomes. And now I'm going to take us through some geographic and regional disparities in addiction-related outcomes. Next slide, please. I don't have. There we go. So during the presentation today, I'm going to use the following descriptions for regions of Ohio outlined in red here on the map of Ohio, and then county type as defined by the Ohio Medicaid Assessment Survey, which divides Ohio counties into Appalachian, metropolitan, suburban, and rural non-Appalachian county types. Next slide, there we go. So in our publication, we identified 3 key drivers of regional disparities in addiction-related harms. They are economic opportunity, stigma, and access to harm reduction treatment and recovery services. Now, we know that economically vibrant communities generally have better health outcomes. However, often challenges related to poverty, job loss, wages, and transportation can contribute to higher rates of overdose death and other addiction-related harms. For example, educational attainment, which is a proxy for income level, is lowest in Appalachian communities and specific school districts in urban areas. And as you can see on the graph here, the overdose death rate is 15 times higher for Ohioans with less than a high school degree compared to those with a bachelor's degree. So strengthening educational opportunities and pathways to employment in these communities would likely improve health. Additionally, we know that safe and affordable housing is necessary to support recovery. However, housing affordability is a significant challenge in metropolitan and Appalachian counties. Can we switch the slide, please? we switch the slide, please? Is it not working?
All right, we're going to switch the screen to make sure that we can see the slides moving. I'm going to throw that up. Just give us 1 second. Thanks for your patience, everyone. Thanks for your patience, everyone. It looks like our slides are frozen and we're having trouble forwarding them. Hopefully just another minute more.
While we're waiting, are they back up? I was just going to say we've been monitoring the Q&A as we go along and putting in responses. So hopefully everyone is able to see those. All right, are we back?
Can everyone hear me?
Yes,
So,
ma'am.
I can hear you.
Yes, there we go. Okay, so we need to go back 1 slide.
Go ahead and go on from here, Lexi.
Okay, great, thanks. Okay, so thank you everyone for your patience. Sorry about our little technical difficulties there. So getting us back on track here, we know that ensuring that substance use disorder is recognized as a diagnosable disease can help reduce discrimination towards people with addiction. And oftentimes stigma surrounding addiction and medication-assisted treatment is a barrier to seeking help. And it's led to a reluctance in some communities to set up harm reduction or treatment services. And this is especially harmful in communities with the most need. This is an example of a poster from a protest of an MAT clinic in a suburb of Cincinnati. Next slide. It doesn't appear to be allowing me to switch slides.
Amy, do you want to take a question or two from the chat?
Sure. Let's see. We had, I know we had a question here about the fentanyl test strip legislation, and that is House Bill 456. And that we put some info in the Q&A if you want to follow the link to see that legislation and more information about that. There was also a question about methadone and why we don't have more methadone providers. And one challenge with that is that it is regulated at the federal level and not at the state level. So advocacy to the federal level is needed. And then I think there was a follow-up with a question about a pilot project that I'm not familiar with. So if you could, Dr. Sawyer, if you could put in a bit more about that, that would be great.
So recognizing, are we done with questions? Okay.
Yep, are the slides moving?
So
Maybe.
Unfortunately, they're not moving, but I'm just going to sort of give like a broad overview of what you would have seen on the slides and sort of hit some key points for you guys. So we're talking about downstream harms of addiction. And one of the harms that we highlight in the geography fact sheet is hepatitis C, which is a disease that's spread through sharing needles and can lead to life-threatening liver disease. And I would have shown you a map of Ohio counties with the highest rate of hepatitis C burden shaded in dark blue. And you can see this if you go to our website and download the geography fact sheet. But what we found was that Southeast Ohio has the highest average rate of hepatitis C infection in the state, and that's followed by Southwest Ohio. And the average rate of hepatitis C infection is 1.4 times higher in Appalachian counties than the average for all Ohio counties. And on that map, there are red dots, which represent syringe services programs. Syringe services programs are evidence-based tools that can reduce the spread of diseases like hepatitis C. And what we found that despite progress, there's still clear regional disparities in access to these services. So what we showed is that 66 of Ohio's 88 counties don't have a single syringe services program. And this includes some of the counties with the highest rate of hepatitis C infection. And so this is a really important example of how the counties with the highest rates of hep C infection and increasing access to these services in those areas can keep people healthy. And then the last downstream harm that we highlight in the fact sheet is overdose death. All the factors that we've talked about today work together to drive regional disparities in overdose death over the last decade, and the heaviest burdens have been in metropolitan and Appalachian counties and are especially concentrated in Southwest Ohio. However, there are many opportunities for improvement, and we can overcome these regional disparities. We can work with communities in Appalachian and metropolitan counties to implement evidence-based strategies such as rental assistance, adult employment programs, and high school equivalency and career training programs. We can engage trusted messengers from social and faith-based organizations to encourage a greater understanding of substance use disorder and reduce overall stigma that can act as a barrier to accessing treatment. And finally, we can ensure that people with substance use disorder in all areas of the state have access to harm reduction, treatment and recovery services, such as MAT, syringe services programs, and drug checking.
Thank you so much, Lexi. Thank you all so much for holding on with us. We have slides back, and that's great because now I get to sort of wrap up what we talked about today. So here's a slide with some common themes that we could take away from the race fact sheet and the geography fact sheet that Jacob and Lexi covered for us. The research tells us that we can reduce overdose death, we could improve overall health, and we can advance equity across groups by investing in these strategies that we see here. We want to leave you today with a quick list of ways that you can use the information we presented to influence policy change. There are lots of ways to get involved in the policymaking environment, both as a private citizen and as a representative of your organization. And if your organization is not able to advocate or to lobby for policy change, there are still many things that you can do to educate policymakers on these issues, including providing data and information perhaps that's contained in the Addiction Evidence Project in one of our briefs, and maybe pairing that with stories or data from your organization or your community. Those sorts of stories can be very powerful for informing how policymakers perceive these issues. There's been some conversation in the chat already about upcoming things, legislation that's being introduced now. We just want to leave you with a quick list of some things that are going on in the policymaking environment that you might be able to get involved in or inform policymakers around. And I know we're over time. Thank you so much for hanging on with us. We'll cover this briefly and then are happy to stay on and discuss more if people have the time and availability. So the first is House Bill 122, all about making those telehealth expansions that we saw during the pandemic, making those permanent, including how insurance coverage and Medicaid coverage works around those expansions of telehealth. House Bill 327 would establish the Office of Drug Policy. This is an office perhaps similar to Recovery Ohio, although Recovery Ohio was created by executive order. This would codify that office and make sure that it existed beyond the DeWine administration. It would have some specific functions that we can talk about if folks are interested. House Bill 456, as Amy mentioned, is our fentanyl test strip decriminalization bill. This would exempt fentanyl test strips from the law that criminalizes drug paraphernalia. The Beat the Stigma campaign was recently introduced. This is a large-scale media campaign to challenge stereotypes surrounding addiction. It's a public-private partnership, lots of partners involved, from the Ohio Department of Mental Health and Addiction Services to the Adam Board of Franklin County to the Nationwide Foundation and others. And then finally, I'll mention the One Ohio plan. This is the plan for distributing, spending the opioid settlement funds that are coming to the state. Attorney General Yost is leading decisions related to that plan in partnership with the governor. And a lot of details haven't been announced about that yet, but money could be coming very soon. So we'll want to keep our ear to the ground related to that. If you all are interested in more related to the opioid settlement funds and the One Ohio plan, the Drug Enforcement and Policy Center is doing a great virtual panel series in partnership with Harm Reduction Ohio related to this. And I'll drop the event series link in the chat so you can register for any of those events if you'd like more information about that in particular. A quick reminder that all the resources from the Addiction Evidence Project are available on our website. If you go to hpio.net and hover over topics, you click on addiction and everything here on the screen will be there available to you. We'll continue to address questions in the chat. And like I mentioned, we'll hang on the call a little bit longer if people want to discuss more. But for now, we're going to throw our poll questions. Our first is related to the quality of today's webinar. We'd love your feedback on the value of the information to you. And whether or not there's anything we can do to make this these webinars more useful. I'm wondering if I'm the one who needs to throw the panel or the poll question, because I know we're having some technical challenges here internally. And I'm not quite sure how to do that. So we're gonna have Alana come join me. Okay, all right. Looks like that's not going to be possible for us to share the poll. So we'll do that via survey after today's event. Thank you guys so much for hanging on with us throughout today. Okay, all of our slides are available on the events page of our website, hpio.net and events. We'll also have a recording of today and are happy to stay on, as I mentioned, to do some more questions. Amy, is there one that you wanted to address for the group at this point? We cannot hear you. No. All right. We're dropping like flies. No, no, we can't hear you. All right. So I'm going to pull up our Q&A off of our main screen here. Thank you, Dr. Sawyer. You're very kind. Okay. it looks like we've mostly answered questions in the chat. So thank you all so much for being with us today. Feel free to drop us a line via email if there's anything else that we can do for you, and we'll see you next time. Bye. Thank you.